Can Okay, excellent. So I'm just going to start the share screen. Bear with me a second. Let's get that going. So, okay, so can everyone see a little PowerPoint thing coming up? Can see that one? Great, excellent. Okay, if you can't see it, then speak up and tell me. Hopefully everyone can see. So I want to do part 2 of this, and then next week I want to try to look at some malnutrition things. But for now, respiratory conditions. So very, very common collection of things, really. But I want to talk about 3 things mostly. Firstly, we're going to go through a little bit of the asthma kind of guidelines, because what I want us to do at ELWA in the next year or 2 is to set up a proper asthma clinic, a little bit like the chronic conditions clinic, but to have something that's specifically for those asthma patients, so they can be coming and going and having regular follow-up. So that's kind of the next phase in my mind, because I know we have quite a lot of asthma patients who come in sometimes in crisis, and we're doing what we can and they're getting better, but sometimes they can be coming and going. They're not too certain about what to do. So I want to talk through that a little. So I just want to go through some questions, a little bit of a recap from last week. So what things in a history would make you concerned that a child might have asthma? Can you tell me some things?
Okay.
Yeah, it's okay. You can speak up.
Yeah, history of recurrent respiratory problems, like in distress. Most of the time, let's say it's repetitive.
Yeah.
And also family history too, from the history. If you gather from the history of asthma with a patient who's also having,
Yeah, so family history of asthma and history of the same things again and again. Oh, some other good thing?
Hello?
Yep, so you were saying about the history of...
I was saying fever.
Fever. Okay, if they're having infective episodes, they might have a fever, yeah. About anything you might find when you're examining a child that may make you think about asthma?
On examination, sometimes person might be wheezing.
Very good. Okay.
Chest.
Yep, sorry, go on.
Chest wall injury.
Okay, chest wall injury, yeah. What about if they've had asthma for a long time and they've not been taking any treatments? Is there anything that you might see when you look at the child? Okay, well, we're going to talk on those in a second. So a few things to think about in the history.
May have hyperinflated chest.
Ah, good. Hyperinflated chest. Okay, good. There's like 2 kinds of that. So there's, do you know the medical word for that? Hyperinflated chests, also known as Pextus carinata. Yep, that as well. We'll just go and have a start with the history. And the main thing to consider is its recurrent presentations. So these children are always coming to under 5 clinic, always coming with the same kind of problem. And they always, it's not just that they're having a cold or runny nose, they're usually having some quite serious distress, or they're having a cough and it's not really getting better. And the mum might say, okay, usually in the morning time and the nighttime, it can be worse. Usually they will not say, I mean, you will have to ask them, because usually they will not just tell you, oh yeah, it's always bad at such and such a time. You have to really push them. And other thing to watch out for is when you have a mom who is carrying the child to all these different facilities and they're giving this syrup, Amox, erythro, augmentin, they try some metro, they're just passing syrups all around the place and it's not working. That's when it's good to think about asthma could easily be a cause there, especially if you're starting to hear some wheeze each time. And then what I've written there about triggers. So we talked last week a little on this, so I won't go on it again, but things like the cold, exercise, those are all triggers. Sometimes they'll say in the dry season, it can be worse. But the other thing I've put family history and also family history of atopy. Can anyone tell me what is atopy? What do I mean by atopy? Yeah, have a guess.
Yes, atopy is like a allergic reaction in our family. Somebody usually comes down with some reaction, like skin rash or maybe respiratory problem when they are exposed to environment also.
Very good. Yeah. So it's a genetic tendency to develop allergic diseases. So that may include asthma, but it may also include things like allergic rhinitis and also very commonly eczema. And sometimes even food allergens can come in these situations as well. So often you may have a situation where the baby mum is there and she says, you're suspecting asthma. So you ask her, do you have asthma? She might say, yes. And I also keep getting this rash all the time on my skin. Or maybe she'll say, oh, and sometimes I can react to like peanuts or something. All of those things they're in a family of atopic diseases. So even when you're asking your family history, it's good to ask the parents, any other history of eczema, any history of like rhinitis, like do they always get fresh cold, and any history of food allergies. Those are really useful questions to ask. And one point I want to put in as well, in children under 2, you cannot really say that they have asthma. The reason for that is they will usually grow out of the wheezy attacks. So they'll have these wheezy times where the child starts to breathe fast, they get the wheeze, but then as they get older, that will start to fade away. So once they are over 2, that's when you will start to say, okay, these wheezy attacks are coming again. We need to be considering asthma. And the reason for that, if you give someone a diagnosis of asthma, it's a very serious thing because you are saying really that they're going to be on medication for a long time in their life and they'll be needing a lot of follow-up, as we're going to be talking about. So that's why it's very important to consider the history. Now, examination, one thing I would say to you is sometimes if a child with asthma is well, then maybe they're coming to continuity clinic, or when we get the asthma clinic going, they'll come, you will not see any findings. Sometimes you'll see nothing. But sometimes you will see in a child who's not been managed too well, or they've had asthma for a long time, you can get these chest wall deformities. And there's really 2 of them. They're both common in asthma. The first one, pectus excavatum. You can see that one there on one side of your screen. And the other side is pectus carinatum. And what's happened is the child has had so many wheezy attacks that they keep basically becoming unwell, and eventually the lungs, as you said earlier, become hyperexpanded. So they become in that chronic hyperexpanded state. So if you see that, it's a sign really that the child's asthma is not very well controlled. So that's when we need to be intervening. Other thing to say, wheeze is really the hallmark of an acute exacerbation. So if you're hearing wheeze immediately in your mind, you should be thinking on asthma. It's very, very likely. And the warning sign I want to say, remember every time you're seeing someone, your vital signs, your most important clinical signs. So what's the respiratory rate, the SpO2, is the pulse getting high, but also something called silent chest. Has anyone ever heard a silent chest? In your practice there, have you ever, like in the ER, do you ever hear anyone with silent chest? So silent chest is basically when you have a very severe asthma or very severe, even in a bronchiolitis child, you'll hear it. And what's happened is the airways have become so narrowed that very little airflow is going. And this is a very dangerous sign. So if you're listening with your stethoscope, and instead of hearing wheeze, you're just hearing silence, then you know that you have quite a big problem. And you know that your airways are very, very, very narrow. So in that situation, you really need to act fast. And I think last time, I remember sharing we had a guide we went through last time for asthma exacerbations. Going to try to get that out in a couple of weeks when I come back to ELWA. And that's a situation where you'll be immediately moving on to that treatment. So just be aware of that. Sometimes if you're listening and you say, oh, I can't hear wheeze, but the child is very sick and I know they have asthma, consider a silent chest. But what I want to talk on today a little bit is more the outpatient management side of it, because this is where we can really make some very, very big changes to how we do things that will have a big impact on the whole kind of public health situation here in Liberia. So something's very, very important is to look at the techniques that are going on. So look at the child's inhaler and spacer technique, and you can see a picture here. You may remember from last time that you can see the inhaler is obvious, but the big yellow thing with the mask, that's called a spacer. And that spacer is being used basically to help the substance from the inhaler to go into the child's lungs very easily. So we have a few of these around ELWA. I'll bring some last time, but it's very important that the family know how to use this. Can anyone explain, how do you use a spacer? Anyone tell me what is what would you explain if you imagine I'm a baby mom and you want to explain how this will be going on? Maybe someone can have a go.
Yes, so usually from what we're seeing on the screen here, they have some marks attached to the spacer. So you tell them to put the marks, so that I will call them off in the nose, and then maybe do like 3-4 puffs per minute. And maybe you can repeat it after 30 minutes.
Okay, yeah, very good. So so what you're going to do, you're going to explain the mum, as you said, put the mask over the nose and the mouth. So make sure it's positioned so that both the nose and the mask are there. And then you press with the inhaler, you count to 30, let the child breathe in and out, and then you can do it again. And if the child is sick, you would maybe do 10 of those puffs, counting to 30 each one. If they're only a little bit sick, then you would do maybe 1 or 2 puffs. Sometimes you can go up to 4. And as you said, you want to repeat that to see if there is an improvement. The other very important education aspect is for the caregivers, so the mums and the dads, to understand when to bring their sick children. So really any child who is breathing fast, any child who is not responding to the inhalers, or who is drinking less. Now, it's very important. This one is often missed because children who are, if they're very sick, they're breathing fast, they will refuse to drink, and then they're at risk of dehydration. So every time you see one of these children in the outpatients, you really need to be educating the mothers and the fathers to say, look, you need to be coming with your child. If you see any of these things, come straight to the hospital. Don't be delaying around. So that's really the very, very important thing in the family practice that you guys are doing. Another aspect of education as well is to be educating the nurses and the PAs, because sometimes they'll be seeing these children. They may not be in the know on these spacer techniques. So it's very, very important to be educating them also. Good. So I want to talk a little bit, we're going to talk about the treatment ladder, but I want to just show you a peak flow meter. We need to try to get these more into circulation at ELWA, but this is how you will tell how severe someone's asthma attack is. And you can see in the picture there on, I think, the left of your screen, you'll see there is a little tube and all these numbers. Now, the way this works is you ask the child to sit up straight, or stand up is even better. And you ask them to blow as hard as they can into there. And you do it 3 times. And whichever one is the best one, that is what you call your peak flow. Now, if a child has asthma, you'll see that their peak flow will be really reduced. And you have a chart very similar to, if you remember from the nutrition, you have your green, yellow, red, same for asthma. You have your green, yellow, and red for the chart, and it's depending on the child's height. So if you have a child and let's say they are 135 centimeters, ideally you want to see them in the green zone. So you would see, okay, their peak flow is coming out at, let's say it's coming out at 200 and, I like to use liters per minute, it's much easier. So 280, then you would say, okay, that's not bad. But then if it's dropping below that into the yellow zone, let's say it's coming out at 150, you'll know, oh, okay, this child's respiratory system is compromised, the airways are narrowed. We need to think about either giving some inhalers, or if they're more sick, bring them on bed. So a child in red zone, if you use the peak flow, get them to blow in, and you see that it's less than these numbers. So you see, imagine, to another example, the height is 160, and you move across and you see, oh, okay, the peak flow is only 180. That puts the child in the red zone. So that will tell you, okay, this child has a very severe asthma attack going on. We need to think about maybe bringing them on bed for some more regular inhalers. We'll be thinking about maybe they even need oxygen, some steroids, all these kind of things. So generally red zone, you'd want to bring on bed. Yellow zone, you can look at managing as an outpatient perhaps. And green zone means they're probably okay. But it's not just the peak flow. Sometimes you may see a child, maybe their peak flow is put them in the green zone, but then you see, oh, they're breathing very fast. They're not drinking, they look very sick. So it's just one of the signs that we use. So it's very important to do it, but not to just be relying on that. So if you don't have one of those machines, then it's very easy. If you're doing an outpatient thing, you can do what we call a trial of beta-2 agonists. So you would give the mother a spacer and an inhaler. You explain really well how to do it. And you say, okay, anytime your child is coughing and getting sick, try giving them the salbutamol inhaler and see if you use it regularly, see what happens, see if the child is improving. If they come back to you and say, you know, doc, I tried that thing, but it's not working. It's not doing anything. It's very, very unlikely that child has asthma. But if you do it and you give it, and the mother comes back and he says, oh yeah, very interesting. When the child starts to breathe fast, I give them the inhaler and everything settles down. That tells you, oh, asthma is a lot more likely. So that is how you can look at your diagnosis. Now I want us to be doing more peak flows in ELWA. So I'm going to come with some machines this time so we can all have a bit of a practice when I'm there in 3 weeks. But just to go through the treatments as an outpatient, and we did a little bit of this last time, but I wanted to go a little more in depth. The first line you're going to use is your salbutamol PRN. So this is an as and when treatment, and this is for children who are usually their asthma is quite well controlled, just sometimes they get a little wheeze. So you say to the mother, I'm going to give you the inhaler. I want you to use it as and when you need it. And then if you see, okay, we're using it and the child is needing to use it maybe 2 or 3 times every week, they're still using it and they're coming back, they're saying, it's working for me, but I'm still always using this inhaler. Then you would think we need to do a regular steroid. So the one we most use is something called Clenil, also known as beclometazone. And you would normally start with 1 puff, you can move up to 2 puffs BID. So if you're using an inhaled steroid, it's okay to do that in a child regularly. It's a very low dose of steroid. It doesn't have the same side effects as an oral steroid. The important thing is for the mother to understand it's a regular treatment. It's not just use it when the child is sick. It needs to be morning, evening, every day. If there's still a problem, and especially if they're having attacks in the night, then you have a medicine. Your third line is something called Montelukast. And you use that in addition to the steroid and the salbutamol as needed. And it's very good for nighttime attacks. You tell the mother usually just to take it 1 tablet at night, usually just 1 to 2 milligrams per kg, 1 tablet at night. And that really reduces the nighttime attacks. If you're doing all that and you think, oh my goodness, the child is doing better, but they're still kind of wheezy and it's still a challenge, then you would use a combination inhaler. So you remove the beclometazone, you give them something which is a combination of a steroid and a long-acting beta-2 agonist. So either Seretide or Symbicort. Those are the two common ones that you will find. And I think we still have some in the pharmacy. But that is your fourth line. And then your last treatment that you want to be using, if you're doing an outpatient management, would be using regular oral steroids. But the problem with that, if you're using steroids too regularly in a child, can anyone tell me what are some side effects of regular steroid use in a child? Feel free to speak up and share. Can anyone tell me some side effects of using oral steroids in a child?
It causes increase glucose. So it can lead, I think maybe it will contribute to diabetes.
Very good. Yeah, contribute to diabetes, also risk of glycemic imbalance. So both hypo and hyper. Any other concern there?
Immunodeficiency too.
Good. Yeah.
It can reduce the immunity.
Very good. Which is why really we don't give a lot of, unless we are dealing with asthma, we don't really want to be giving lots of steroids, especially in the under 1 age category. We really want to be moving away from that. So that's good. Yeah. Anything else steroid can do? Any other problems there?
Other way aware of.
Okay, so the other thing is growth retardation. So if you give someone steroids too often, then you can get growth reduction. Can I just double check? Can you all see the pictures? Can you all? Oh, something is happening. Oh, can everybody see the slides? So just want to check.
Yeah.
You can all see the slides, good, because my computer was doing some strange things. Okay, that's good. Excellent. So yeah, so 3 things really: risk of diabetes, growth reduction. Those are your two sort of common ones that you're most concerned about. So, and then immunosuppression is a big concern in the very, very young children. So that's why we want to be a little bit careful with using steroids too regularly. So inhaled steroids not a concern, but the regular ones, it's more of a concern. So, okay. So just to move on a little bit, I want to talk a bit about TB. Now, TB is, I mean, it's everywhere, isn't it? We see a lot of tuberculosis at ELWA, but we see it everywhere. When you go to Harper, to Maryland, you'll see it there. We have TB Annex. We have all these different places that are trying to treat it. And what I want to just get across is children will present a little differently to adults with TB, because really they will not often have the same symptoms, and it will often be something that's been rumbling for a long time, and they've maybe taken a bit of treatment somewhere and they're not finishing it, so they go some other place. And what I want us to discuss some ideas is how we can really encourage our children and mothers to be bringing these children regularly. So just to say as well, they may not come with a cough. That may not be the first way you see them. It may be that they've had a cough some other time, they got TB, and then the TB went and it became a chronic sort of TB. Maybe there's a lung abscess developed, but then the reason they present may be abdominal pain or maybe spinal deformity. So I'm just going to share a little bit about some of those different presentations. But before, I want to just give us some ideas, and some of this is based on the MSF guidance really, of when do we think about TB? So really there's inpatients and outpatients, and obviously this is a child, I don't think this child actually has TB, but I just wanted to show you an example of a child in the IPF. Really any child who is in the IPF, TB should be in your mind. So it should be, you should be thinking, is it possible this child has TB? And I want you to consider it, especially if you see that the growth is not improving despite the child taking all the feeds. So when you do your round in the IPF, we'll talk on this next week a little, but there's a feeding chart. It will tell you how much of the feed the child is taking. It will also tell you the weight gain. Is the child's weight increasing, or is the child's weight going down or just staying the same? And if you have a child where the weight is just staying the same, but they're taking all the feeds and they've been sitting in the IPF maybe for 2 or 3 weeks, something like that, you should immediately be thinking, could this be TB? Even if the child does not have a cough or a fever. Secondly, any child with persistent fever. So imagine they come to the IPF, the first time you treat them, usually their nurses will start them on the AMP and GENT, and you're seeing them, you say, okay, we'll give them 2 or 3 days. You try a few days, still no improvement in the fever. So you change, you maybe try azithromycin, something. 3 or 4 days later, still no improvement. And you're listening to the chest, nothing is there. Your spot test is negative. You can't hear anything. Urine test coming negative. Everything is negative. And then you suddenly see, okay, the fever is still there. In that situation, I would have TB in the back of my mind, because remember, it can be in any organ system. And also any child who is persistent chest signs. So really the sequence, once you've had one lot of antibiotic, if you're not seeing an improvement in the chest, move to a second lot of antibiotic, still no improvement, then you need to think about TB, especially if you're still hearing crackles or reduced breath sounds in one side of the lung. Those are situations where you need to think about it. Now, I would also put in there about contact with TB as well, but you have to be aware, you know this much better than me. When you're asking a family, is there any TB in your community? They'll always just tell you no. They will not say, oh, yes, my uncle has it, my auntie has Cox disease. They will not say those things. They will just kind of keep it to themselves. So that's why it's good to ask contacts, but sometimes you will have to do it in a different way. So you have to ask if they are taking treatment, or you'll have to maybe take them into a little private room somewhere. You can have a little conversation with the mother, ask if something is going on. So all those things are very, very important to consider. And especially the other thing I want to say is children with a persistent oxygen requirement. Generally, children they're not usually on oxygen for a long, long time unless they have a heart problem or TB. So it's worth considering that. So really, those are your things: your 2 antibiotics, no improvement, persistent fever, and lack of weight gain. Those are all situations where you want to consider TB. And outpatients a little different, but I would consider that any situation where you have children coming to under 5 again and again, or to the OTP, and they just keep coming, and you will see you have the 2 PAs, they have Sata and David, they're there. When you're doing your peds rotation, it's very good to spend some time with them, because they are very good at recognizing the children who are not improving on the Plumpy'Nut. And if they see there's no improvement, what they will do is they will very rapidly say, okay, this child, we need to find out why the child is not improving. We can bring them on bed, do some investigations. Other thing as well, recurrent fevers, really, if you see a child who keeps having a cough and fever, you can give them antibiotics maybe twice, but beyond that, you don't want to just keep giving them antibiotic syrup. You want to start some investigations. So maybe getting a chest x-ray or some other kind of something is a good idea. And this other thing I was saying, faltering growth. So even a child who maybe they're not even on the nutrition program, but you see the mom says the body is getting dry. When he first came, he was very fat, and now his weight is just going down. That should also make you think. So also unexplained presentations in older children. We're going to talk on those in a moment, but it's really good when you're doing your peds rotation, try to spend at least one morning each week in the under 5 clinic, because you will see a lot of these children for the first time coming through there. And you see high volumes of children. And it's really the important thing there is recognizing which ones are the sick ones that need to come on bed, and how can we do our further investigations. So very, very important to consider that. And I just want to say that a little thing we all know, and there's probably in your internal medicine, you may have discussed this already, but TB and HIV, I always tell people they are like the evil step parents. They come together and they always cause problems for the child. So just remember these simple things. Everyone with TB, you must get a spot test. And anyone with HIV, you've got to think about TB on some level. So how you do your TB test, we're going to talk about that in a second, but really, ideally, we want to get a gene expert sample. Now, I know the gene expert machine has been running into a lot of constraints. Is it working? Is gene expert working in ELWA now? Does anyone know? Maybe it's not working. Okay, but if it's working, try to use it. But the one thing I would say is if it's not working, it's not a disaster. You can still get a chest x-ray. And what I would say is usually getting sputum from a child is not easy. You can try and you can do a little bit of lavage where you almost induce a bit of vomiting and you get some sputum out that way, but it's not easy. So chest x-ray is actually perfectly okay if you want to do that. And then also you can make a clinical diagnosis. So if you're in a situation, I know we had this constraint, the x-ray machine was not really working. And if both x-ray and gene experts are not working, then you can say, well, we're going to call it clinical tuberculosis, and you're perfectly okay to start on some treatment in that situation. So what is it? We all know a little bit of this. Multi-system, we all know it's a microbacterium. But the thing to be aware of, this is an insidious onset. It takes time. So it's not, oh, someone's had a cough, let's put them on TB. This is a long history. And especially in a child that you will probably find they've been to several health facilities already. Sometimes you will only see a fever and you will see the child is not really gaining weight. And that is something which can go on for a long time before you get any improvement. Other thing I would say as well, TB is treatable. Now, one of the things, you probably know this again better than I do, is TB, the parents can really be in a state of despair when you speak with them and you tell them the child has TB, they can really go down. So it's very important to try to find ways of bringing the child and the mother so they are kind of on your team, because you can make a huge impact on the treatment. It doesn't have to be the child is just, sitting there getting dry forever. You can do very well for that. So we got 2 x-rays here. What can anyone tell me, what can you see in the first x-ray? The one on, I think on the left of your screen. Somebody tell me what you can see. Oh, anyone still there?
What? For me, on the left, I'm not the left but the right, the helium of the along the mediastinum.
Very
cool. A little bit.
Yeah.
I don't have the cross on the point area, but
yeah, very
close to the arch.
Yeah. So the first one, you can see a bulky right hilum, and what's going on there is hilar lymphadenopathy. So you actually have TB that's gone into the lymph nodes. It's not too clear, but you can definitely see the right side of that hilum is very bulky. So that's also TB. What about on the other side? What can you see? It's very.
It looks like on the upper lobe, right upper lobe.
Very good. Yeah. Do you know what that's called? How would you describe it? Okay. So, I mean, I would describe it as a cavitating lesion. So if you look at the right upper lobe, you can see there's an area of consolidation. And then in the center of that, you can see a little black circle. And that's basically just a patch of air. And what's happened there is the TB has basically infiltrated the right upper lobe and essentially caused a collection of sort of mycobacterium to form. So that's called a cavitation. And if you see a cavitation in the upper lobe of a chest X-ray, very, very likely to be TB. On the left side of that one, you can also see a little bit of, well, basically a bit of thickening really in the upper lobe, and almost possibly the beginning of a bit of a consolidation left upper lobe as well. And there's certainly a bit of a bulky right hilum. So, I mean, the first X-ray is more subtle, but the second one, that is straight away, if I saw that, I'd say, wow, that's straight away TB. That needs treatment immediately. And there's some more happy X-rays. You can see, I'll just go through these now. One has a little bit of a CT scan as well, but you can see on this side, this is a much younger child. This is what I'd call miliary TB, and the tuberculosis has gone all the way through the lungs. You can see really sort of patchy shadowing, kind of reticular nodular shadowing really throughout both lung fields, especially on the left side actually. And that's actually a sign of really quite late stage tuberculosis. So that patient has had TB probably for some years. And then the other one here, you can see really two big things you can see is a huge cavitation on the right side, right on the far right. And then also cavitations on both of those X-rays as well. So really, these are very kind of late stage tuberculosis. Quite rare to see a patient with such florid conditions. But that is very much pathognomonic of TB. And you can even see on the CT scan there, the damage that's been done to the lungs, and those cavitations, there's not even any air, there's no alveoli left in there. That's just essentially a collection of loose air. So another form, TB lymphadenopathy. Any child really with very swollen lymph glands, you should be thinking about TB lymphadenopathy. And you can also see that the medical name for that's also a scrofula, is what you would call that. Very, very swollen glands, very common in the cervical region and sometimes in the submandibular region as well. Quite swollen glands behind the ear. And when you palpate them, they're usually firm, sometimes painful. This little guy's got a bit of discharge coming out from just underneath there as well. So this is quite common. I mean, children have swollen lymph nodes all the time. And a lot of the time, it's just a bacterial infection. But if you're finding that it's not improving with multiple antibiotics, then I would be considering TB. The other thing in that situation where you see raised lymph nodes as well, you need to think about a hematological malignancy as well. It's quite common to get various leukemias and even lymphomas that just present with very, very enlarged lymph nodes around the neck. So I would probably, if I saw that and it wasn't responding to antibiotics, I'd want to at least get a CBC to see, is there very high lymphocyte count, very high neutrophil count, high white cell count. Those things would all be very, very helpful. Everyone can see this. Have you guys seen children in this condition? It's very sad when you see this. I mean, this is, I've given you the answer already, it's Pott's disease. It's TB of the spine. And just be aware that some children will present in this condition. Even they may not have been treated anywhere. It's very, very common in the sort of more rural areas. And I mean, we had one, when I worked in Freetown with Mercy Ships, we had one child who they came to the clinic, we diagnosed TB in the chest. We started them on the dots. They're on dots for maybe a week. And then the child was taken into the interior and we did not see that child for another year. And when they came back the next time, they already had Pott's disease. It was so frustrating because by then they had irreversible nerve damage and very, very hard. So trying to prevent these kind of things is why we are so focused on the kind of public health aspect. Abdominal TB, I thought this was a good picture. Now, surprisingly common, and again, undiagnosed a lot of the time. People sometimes misdiagnose as appendicitis or Crohn's disease, various other kind of conditions that can be there. But abdominal TB really, they come with often abdominal pain, not usually just 1 or 2 day history, but a long history, usually kind of chronic diarrhea. They've not been eating very well and they're losing weight and they're just sort of going down very, very steadily. And just be aware if you see that, certainly a child who is malnourished, has diarrhea and is losing weight, and the diarrhea has been going on for maybe 1 or 2 years, something like that, there's only 3 things it can be. Either they have inflammatory bowel disease like Crohn's or colitis, or they have a chronic bacterial or giardia or some kind of infection, or the third thing would be abdominal TB. So it's worth having in the back of your mind if you see a child with really bad abdominal pain and fever and night sweats and all these kind of things. And occasionally we've had 1 or 2, I think the surgeons have picked up, where the child's actually had an obstructed intestine, and it's created a huge issue. So brief word on diagnosis. We talked on this a little already. So just to be aware, really children don't produce a lot of sputum. Sometimes the testing isn't always what it should be. So just be aware that it needs to be considered. And one thing to know, when you have coexistent TB and HIV, you've got to start your treatment of TB early. So at least 2 weeks before starting your antiretrovirals. Can anyone tell me why? Why would you do that? Why not just start the 2 at the same time? Someone have a guess?
No.
Yeah. Yeah, so you can unmute yourselves and share some good answers. What do you guys think? Why do we not want to just put someone who has HIV and TB? Why not just start ARVs at the same time as DOTS? Why not do that?
I think one of the things should be the overburdening the patient with the medication. If you're starting DOTS at the same time ARV, there could be crossover.
Okay.
Medication they're receiving.
Possibility.
But what I know of is usually we try to treat the TB first, the opportunistic infection, for about, I think 2 to, I'm not sure of the time, but it's initiated first before starting the ARV.
Good. Yeah, good. That's very true. So the big reason, and you're absolutely correct, you can have interactions, but the big reason is something called IRIS, so immune reconstitution inflammatory syndrome. And the reason is if you start your ARVs while you have all these kind of untreated sort of coexistent conditions such as TB and what have you, what will happen is the immune system will wake up, but it will immediately start overreacting. So you'll find that the patient will really deteriorate fast. So that's why starting the TB treatment first. Usually you want them on the DOTS for 2 weeks, and then you would move on to the ARVs as well. So that's the thinking there. So the way I like to explain it, it's a little bit like if you imagine ELWA security has become, if you say, you know, ELWA security is no longer there, and all these people are rushing in and they're all trashing the place and stealing things, then you will find, you know, that there's a problem. But if you just suddenly bring the security back and you say, okay, none of these people can ever leave the compound there, and they'll just keep trashing everything, but they'll become even more violent because the security will start to fight with them. So what you do before you close the compound is you take out all the bad things. So it's like the same with HIV. What you do before you put up the body's defenses is you start the treatment of all these conditions, and then you start putting the defenses up so they don't come back. But you have to be very careful. By definition, anyone with a diagnosis of TB has at least stage 3 HIV. If it's extrapulmonary, at least stage 4. So that's quite a late stage of treatment. And really, you know, anybody with TB and HIV, they are going to be on ARVs fairly soon. So that's why it's good to explore these other things. Getting a chest X-ray started early, that's always a good thing to see. if you're suspecting it. Good. Okay, just moving on to some of the treatment courses, and you'll know this. I'd really encourage you, if you have time, spend a little time with the TB treatment people who are in that little annex. They're only really there until 2 in the afternoon, so you'll have to go early to find them. But 6 months early, 6 months treatment is pulmonary, and then you would move to like 9 to 12 months for extra pulmonary TB, if you're seeing it outside of the lungs. And remember, you're starting with your 4 medicines. Are still the same 4: rifampicin, isoniazid, ethambutol, pyrazinamide. Normally in a standard situation, you go down to just those 2. But remember, you do need B6 and pyridoxine, it's often referred to as. It's really, really important to start that as well, because that reduces your risk of neuropathies. And these children need follow-up. What you have to try to do, it's not easy, but make sure that they are actually coming back and forward with their child to the hospital. Sometimes they will, oh, I can have my 2 weeks of treatment and then I go. And that really makes a huge problem, because that's what leads to the resistance and all these other things. So it's good to watch out for any signs of, I mean, we know liver dysfunction, particularly rifampicin and isoniazid will do that. Neuropathy, so ask them, are they getting pins and needles? Are they feeling weakness in their arms or legs? Sometimes you may need to ask the mother to help you with that. Isoniazid is the big one that can cause that. And then examine them for jaundice. You may even want to look at briefly examine their neurological system. The other thing with ethambutol as well is it can affect eyesight. So it's worth asking about eyesight. Okay, it's question time for you guys. What are some problems that you're seeing in keeping a child on TB treatment? Have you encountered any problems, or is it always very easy?
I'm not ready to start on TB treatment.
Okay, so no really tried yet.
You're talking about the facility or the patient?
So the patient, so why is it that sometimes you will start a patient on TB treatment, they take it for maybe 1 month and then they run away? Can you tell me any reason why? Does anyone know why that can happen?
Yeah, sometimes I think side effects of the medicine. So it could be starting the patient also of what they should expect, and make sure labs are done where they stand, so to get that before starting the treatment. And sometimes it is very solid, taking medicine early in the morning. So the most, I think one of the main things is also things that they might expect. Yep.
Yeah, okay, so yeah, that's sometimes the side effects of the treatments, and difficulty transport is sometimes an issue. I mean, do you guys have any ideas how we can try to help in that situation?
It's just to counsel the patient parents.
Mm-hmm.
Or maybe if the problem is transport, as we said, maybe to provide some small funding for transportation until they can get a person to start coming for the medication.
Okay.
And thing, say, constant follow-up, if possible, like for decision, if we know the home, we can go around, because some the medication, the person can afford feeding and all these things, so available for them, because some people may not have much to eat and taking medicine, so we have to know what's happening at home to help the patient.
Yeah, all really good ideas. So understanding a little of what's happening at home, good counseling, explaining things. Other ideas, trying to have a friendly environment, maybe a way to keep things confidential so they're not feeling shame. All those kind of things are really, really important. So yeah, that's yeah, absolutely. All of those things are very, very good to think about. And also, one other thing sometimes is if they understand there will be some side effects, but they still believe that it's a good thing to be taking the treatment. Sometimes they are more likely to keep going. So it's really good to make them aware at least some of the side effects and explain why it's not really too dangerous to be on some of these things. So yeah, that's all very good. Other ideas I had as well, there's something called a buddy system, where it's like often you'll have like two families, both of them are taking treatment, and the TB person will say, hey, you guys are living kind of close in the community. Can you both try to be encouraging each other to come? It's a little bit like, you know, at home we call this viral marketing. Like something is working out well, you know, maybe people are getting to know about a hospital or a program, and they say to their friend, hey, you can go to that hospital, they're good, they will treat you good. And then more people start coming. So as well, they need to review it 2 weeks, and then really every month that should be happening. And your things you're asking them about, I mean, urinary discoloration is very, very common and not really a concern. It's rifampicin that does that. But the neuropathy, you need to be following. Jaundice, you maybe want to do liver tests, perhaps maybe once or twice during the treatment cycle. You don't need to do it all the time, but especially if you're seeing jaundice and the child is becoming more lethargic and more weak, then you need to be doing liver tests. We had one child, they were actually in that small tetanus room a little while ago, maybe 2-3 months back, and they were taking their TB treatment. They were doing well on the treatment, but their liver tests were going the ALT especially was going very out of hand. So we had to make some little changes. And as well, look for signs of resistance. So if they are taking treatment very faithfully, but they're still not improving, then you're into thinking about resistant TB. And we're going to talk about that a little bit now, if I can make it work. Medicines. The situation is a little more complicated. So there were some new guidelines that came in 2019, basically some of and these are sort of WHO things. So it's different in every country is another complication, but putting some of the second lines into various groups. So you have your group A's, your group B's, and your group C's, and you want to try to have the various medicines kind of all coming from that one group. So really the kind of more follow-up guidelines, there is not exactly a hard and fast, this is the way you must do it, because some settings have more availability than others. So some areas you may find that, for example, you know, clofazimine is not readily available, but say you have lots of levofloxacin and you find linezolid, you'd probably be using that group instead. And other times it may be, okay, we've seen some resistance, so what we're going to do, we're going to try a bit of meropenem and some streptomycin as well. But the guidance now really is more just with some general principles. And firstly, the idea that you'd want to still try and get a gene expert test to give a sense of, well, are we dealing with a resistant or a multi-drug resistant bacteria here? And that's where a gene expert can be very, very helpful. And really, varying principles would sort of include that you want the child to be on something that you know they're going to tolerate. So just be aware, for example, streptomycin, it's not bad, but you're doing it usually as an injectable, and it can have really bad effects on the kidneys. So you've got to be very, very careful with streptomycin. So you may, in a child, you may want to move back to, say, using levofloxacin and linezolid instead, perhaps swapping out your, you may continue your frampazine and isoniazid, but you're putting in levofloxacin and linezolid, and that would hopefully sort of get you through. So just to be aware, you'll see if you've noted from the first treatment, most patients are already starting on some group C medicines, usually on ethambutol and pyrazinamide, and you may just want to perhaps look at sort of adding in something different if they've already had that. But the principles really are you want to try to keep them on a second line regime. You're looking at usually about a year to 18 months to completely eradicate the TB. Now, it's very important they're compliant. And you want to try to avoid excessive injectables because really children, they often will not comply. The mothers will not bring them. So if you can, try to use an oral regime. Now, the guidance keeps changing very rapidly. And I'm aware that there was some real challenges in ELWA with getting hold of the second line TB meds. So what we should probably try to do in the next few weeks is find out what we actually have at the moment. So something I want to touch on very, very briefly, anemia in HIV patients. I'm talking more on older children. If you have a severe anemia in HIV patients, probably that patient also has TB as well, because it will have infiltrated the bone marrow. So if I'm seeing a child, maybe they're 7 years old and you see the HB is like 3 and they're spot reactive, I'm going to think, right, that child needs to be on DOTS first. The reason is, even if you're seeing nothing on an X-ray or anywhere else, almost certainly you're going to be dealing with a TB that's affecting the bone marrow, and that's quite serious, really. So I would start with my DOTS in that situation. Last condition I want to talk on very quickly, and then we'll do some questions and things at the end. Pleural effusions, not to be missed, but not very common, but important that we know about them. So let me take this away. Can anyone tell me some signs of a pleural effusion? Like when you're examining someone, what would you find if you have pleural effusion? Yeah, you can unmute and have a guess.
So we have, when you're examining, especially you find dullness on the side is affected with the pleural effusion.
Very good. Dullness to percussion, yeah.
Yes.
Anything
Yeah,
else?
Yeah. Dullness, that would be, I would say asymmetry of the chest wall sometimes, especially when the person is expiring.
Yeah, very good. Asymmetrical chest wall, very, very good. Yeah. Yep, so two things. I mean, the other thing as well is reduced breath sounds when you're listening. So usually reduced breath sounds on one side. So you're absolutely right. Uneven chest expansions. I mean, you may even see that in an older child from the end of the bed, but when you're doing chest expansions in a child, you still, there's a similar way to how you do it for an adult. You have your two thumbs on the sternum, you rest your hands and the child's breathing in, and you just see if your thumbs are expanding equally. So I've seen maybe 3 or 4 of these kind of children in ELWA so far. One had a very, very complete sort of, complete whiteout and needed a drain, and just presented with persistently low SpO2 sats and a persistent fever. And often what you'll find is the child will have just persistent signs which don't improve. And you've been trying antibiotics, you've been trying, maybe you can put them on TB treatment, and then eventually when you get the X-ray, you'll see it. So just to show you, there's a couple of pictures. I mean, you can see the first one is really a younger child. And you can see the right lung field is completely obscured. You can't really even see any lung markings. It's because the whole of the lung, the whole of the pleuris, has become full of fluid. So a child like that, you will probably see all those signs. What about the second one? What can you see on the second X-ray? Anyone tell me? Quite a lot of different things.
So on the second X-ray, it looks like something is pushing the right lung.
Good, yeah.
And there's a little bit of effusion.
Yeah, very good. there is a bit of an effusion on the right side. So you can see the lung markings no longer reach to the ribs, and there's really a bit of an infusion really all the way around the lung. What about the left lung? Anything there?
Yes, you don't see the tissues clearly.
Good. Yeah, so good. So there's a little bit of an effusion at the base of the left lung, but really the left upper lobe, I mean, you could say that that could either be a complete collapse, or it could also be quite a large effusion as well there. And you can sometimes get effusions that are just tied to one lobe of the lung. And the reason I say that is you will, if you look, you can see that the area there with the fluid in kind of follows the dividing line between the upper and the lower lobes. So there's quite a lot of fluid really in the left upper lobe that's just kind of sitting there. So I would say there's actually bilateral pleural effusions in this child. So just to say a couple of things, that's going to need a chest drain insertion. It's not something I can lecture you on. That's something we'll need to do clinically. Now, if you have a small effusion, you can actually just aspirate it using an ultrasound guided needle, or you can even just do that clinically. But the main thing is always need to consider why, because if you don't, that effusion is just going to reaccumulate. Most common in children is parapneumonic effusions, and especially if you've got a nasty kind of aspiration pneumonia. So the reason I've put this in is because we do now have the inpatient feeding program. And if the feeding's gone a bit wrong or the child is aspirated, it's always good to be aware of the risk of a pneumonia, and by definition, then a pleural effusion. And the other thing as well, consider TB. Just be aware a pleural effusion is extrapulmonary. So that would be you're putting them on a years-long course of anti-TB meds if you're doing that. So it can be a very substantial effusion sometimes with TB and also with pneumonia. Both of those things can be there. So just be aware of that. And it's just a condition to keep in the back of your minds there. So I just want to touch on something else. Who needs x-rays? And it's very tempting to go too far one way or too far the other way. And what I'd say, most children who come through, you don't really need a chest x-ray, because if the reason you're doing one is to basically you're asking a question which is going to determine which way you're going to move your treatment. So if you have a child who is, you can hear an obvious, like obviously it's asthma, or obviously you're hearing pneumonia, you're starting your treatment, and you don't need an x-ray to confirm pneumonia or to confirm asthma. You would just make your start on your treatment. And the reason I say that in a child, certainly where I live here in Wales, we don't do a lot of x-rays on children because of the radiation exposure. So that's why your clinical diagnosis is really, really important. And be aware as well, if you have a child on oxygen, you can't, one of the challenges in ELWA, you can't just say, go carry the child to x-ray, because if you take the child off the oxygen, you carry them for x-ray, and then they come back, they may not have had oxygen during that journey. So that can be quite challenging. So at times when you need to, really, if there's no response to initial treatment, so for example, you've had a child, you think they might have TB because you've been treating them, they're not improving. And especially if you have any signs. So if I saw a child and I saw, dull percussion, there's reduced breath sounds, I would say, well, let's have a look at getting a chest x-ray here. Let's see what we can do. And similarly, if I'm not seeing improvement, and maybe I'm suspecting something else, like occasionally if you have a child who's been on CPAP for a long time and suddenly they deteriorate, you might want to try to get a portable x-ray just to make sure there's no pneumothorax. So it's worth thinking in those situations. But really my summary is you don't need to always do x-rays. They're very, very good in some situations. So a situation where you need to know an answer to a question, but most of the time it's not really needed. And the other thing as well, I mean, CT scans in children, also you would only really be doing that if you want to look at maybe the size of an effusion, or if you're looking at possibly some kind of malignancy. Because if you think about a CT scan for a child, you know, any under 5 that you put through a CT scan, you're going to potentially drop their IQ by 10 percentage points. It's a huge dose of radiation. So just worth bearing in mind. Very useful in the right situation. If you're considering TB, if you're worried about an effusion, if you're worried about a pneumothorax, some other thing, do an X-ray. But if you've just got a straightforward pneumonia or you've just got a straightforward wheezy illness, it's not always needed. So just good to think about that. Oh, oops. So just to kind of basically come to some conclusions, really beware TB, any age of child, worth thinking about if there's no response to treatment, especially faltering growth. Look at stepwise approaches to asthma treatment. So I really do want to try and get an asthma outpatient service going at ELWA. I think it would be really excellent. And I think it's not a particularly costly service to run. I think we could do it at a very high standard without really, without really using huge resources, and we would have a big, big impact on these children. And then also think about, just remember any situation, your emergency signs, we went through them last week, but any child who has really these severe respiratory distress, low O2 sats, you're into your emergency breathing management. So there we go. So thank you for listening. We'll have a little time for some questions. Maybe I'll stop this screen share just briefly. So any questions from you guys?
Thank you, Dr. Mikey, for the presentation. So you are talking about rifampicin and acetylcholine causing liver dysfunction.
Okay, yeah.
If you notice that you are treating your patient with TB and they having liver dysfunction, what is the next choice of drug?
Okay, very good question. So you're in a situation where rifampicin and isoniazid, you're treating your you're treating your TB, and you're getting into really bad liver dysfunction. Well, then you look really at your sort of your second line regimens to see what you have available. And personally, I would probably go with the sort of the group A medicine. So I would usually want to use levofloxacin and linezolid. But you can also quite equally just say, okay, well, we're going to stop those two or one of them and change to just ethambutol and pyrazinamide. I think in Liberia, with the setting we're in, what we find ourselves in, I would probably stop the rifampicin first, continue the isoniazid, and restart ethambutol, restart pyrazinamide, and review the situation in 2 weeks. If the liver is improving, then you're winning and you can basically continue. If the liver is getting worse again, then you need to stop the isoniazid as well. So I hope that explains it. But everything is a balance. So you'll expect a little bit of liver dysfunction, but if it's very bad, then you would need to stop personally, I would stop the rifampicin first.
Okay, thank you.
Good question though, very good question.